So let's move on to CheckMate 816 or a neoadjuvant approach. This is the only approved strategy for neoadjuvant chemoimmunotherapy that we have. So here we use chemotherapy plus nivolumab immunotherapy in the preoperative setting. So patients with stage 1B to 3A resectable non-small cell lung cancer receive 3 cycles followed by resection. Robert, I'm going to ask you, we saw the results, positive event-free survival, positive overall survival. We saw update at ASCO 2025, which was really impressive, showing now, 5-year overall survival benefit for non-small cell lung cancer. We had PathCR, patients with PathCR had a 90% reduction in the risk of death by 5 years compared to those without a PathCR. And so this was like, to me, really a paradigm shift and made me think more of using a neoadjuvant approach. But I want to hear from you, like, in your opinion, are there patients that you're more likely to use a neoadjuvant versus perioperative? Is that more of a medical oncology thing? How do you choose?
That's a great question. I think, giving it up front in a neoadjuvant setting, the CheckMate 816 was really our first neoadjuvant immunotherapy study, which showed a clear benefit. And we did pivot pretty early after that study was published to using a neoadjuvant strategy. I think the interesting question is, for the patients who don't have a major pathologic response or path CR, and they still have significant residual disease in their pathologic specimen. What do we do if we're slated for the neoadjuvant strategy? Because clearly, they didn't really get much of a benefit from the neoadjuvant immunotherapy. And that could be because of the low PD-L1 expression, which is most likely the reason. And then adding additional immunotherapy in that setting, I don't know if that would really add additional benefit. Or whether that really drives the decision making, whether you do neoadjuvant versus perioperative. I think one of the important things is to, as we mentioned earlier, you need to do biomarker testing. So if someone has an EGFR mutation or an ALK mutation, they're probably not ideal candidates, for the neoadjuvant immunotherapy strategy. It's interesting in those studies, they didn't really use PD-L1 expression as the eligibility criteria. So some of those patients did have EGFR mutations. So I think in our current practice, we've kind of refined that where we do the NGS, we do the PD-L1 testing, and in our practice, if someone has less than 1% PD-L1 expression, we probably won't recommend them for neoadjuvant immunotherapy or perioperative immunotherapy. We may opt for a different strategy in those patients. So I think now we're using the biomarker testing to really select patients, for the neoadjuvant immunotherapy strategy versus perioperative. I think that's going to, I think in the future really drive decision making.
Robert, are you saying that if a patient has very low PD-L1 but doesn't have any driver mutations, you would still not give them IO preoperatively?
We probably would elect not to or discuss it. We've had a few patients that progressed on neoadjuvant immunotherapy who were had low PD-L1 expression. So that's kind of influenced some of our decision making in terms of using the PD-L1 expression as our driver in terms of the decision. So yeah, in those cases where it's less than 1% expression, we may opt to, move to surgery and then adjuvant, chemotherapy in certain select situations.
We tend to give neoadjuvant chemo IO to really anybody in whom it may be appropriate, which is becoming an earlier and earlier stage subset, as long as they don't have an oncogenic driver. We don't like to give it to patients who have known mutations for which it's potentially going to actually worsen their outcomes. But we'll give it to really a wider and wider range of patients. I think one place that we've shifted in recent years is that, when a lot of these trials first came out, you'd be very tempted to think like you needed to stick with one specific regimen as it happened in the trial, exactly as it was done in the trial. And so if they had it perioperatively, we had to do it perioperatively the exact same number of cycles. And if they had this drug beforehand and this drug after, that's what we needed to do. No mixing and matching, no changing, no shifting. But, you know, as more and more things have gotten approved, I think we're recognizing the importance of kind of tailoring and personalizing a specific patient's care. And ultimately, I think we're making more and more decisions about adjuvant therapy based on the response, you know, the pathologic findings and the pathologic information, because ultimately, while we see great results and an important benefit to the immunotherapy as part of the patient's perioperative regimen, in patients for whom we don't see much of a pathologic response, you know, we tend to feel like adding risk of additional toxicity without any guaranteed benefit is, or unlikely benefit, is probably not worth it. Whereas anybody who's already shown a pretty good response to it, we hope to really target any kind of unknown microscopic disease that may be lingering with the addition of adjuvant. And so I would say that's the one big shift that we have had recently, is that we're kind of a willingness to depart from the regimen as it was, you know, described in the study, to try to really tailor it to the patient's pathologic findings. I don't know if others are doing that as well.
And so in say the scenario where you give it, they have a PD-L1 expression less than 1%. It's exactly a 4-centimeter tumor, and then on the final report, there's literally almost 100% tumor viability with no real tumor destruction, and they may have 1 or 2 positive N1 nodes. In those cases, what do you do afterwards if there's minimal to no response to the neoadjuvant immunotherapy?
Yeah, I think that's a tough situation to be in. I think, looking at the PD-L1 expression as being negative, in our practice, I still would give the neoadjuvant, because I feel like that would be potentially better than chemotherapy alone. But recognizing that the higher the PD-L1, the greater magnitude of benefit from these strategies. In the case of somebody who now post-op, despite chemo IO, has 100% tumor viability, that's a very poor prognosis situation. I don't know that giving more of the same is going to make any difference. Would I do it? I would have a discussion with the patient. I would certainly try to enroll that patient in a clinical trial. There are a lot of ongoing clinical trials that are trying to answer that question. What is the best strategy for patients who don't achieve a path CR? There's ECOG Akron studies with the Clear and Insight study that we're a part of, and we have other industry sponsors that have multiple studies that we're very interested in looking at. So I think really those patients, that's a high unmet need. And really, we should be talking about a clinical trial for those patients, in my opinion. But can I back up a little bit? Because you said something that was very important, which was, trying to select the patients who you think are going to be optimal for undergoing a preoperative strategy in the beginning, but thinking about risks and benefits and side effects of, if they have sort of poor prognostic biomarkers, should we just go straight to surgery and not even risk it? Have you had concerns about using chemo IO in the preoperative setting, that it could impact surgical outcomes in a negative way? I mean, I think all these trials had surgical endpoints that were actually pretty reassuring, that you got more R0 resections, less rates of pneumonectomy. Have you had a different experience? What are your thoughts on that?
I think the safety profile has been, very good for the, immune checkpoint inhibitors. I've maybe seen 1 or 2 cases of pneumonitis, which resulted in a slight delay in surgery, but we were able to eventually take those patients to surgery. So I really haven't seen any increase in post-operative complications. We've been able to perform robotic minimally invasive surgeries in these patients who receive neoadjuvant immune checkpoint inhibitors. No high conversion rates, great post-operative outcomes. So I really haven't seen any increase in post-operative complications or issues in the post-operative setting, with the neoadjuvant strategy. So it really hasn't impacted our outcomes at all, if any.
I would say we've had a similar experience. We all anecdotally have the patient whose operation got delayed because they had pneumonitis, or even the patients where we thought they had progression and it was pseudo progression. And we've had different postoperative complications than from chemotherapy alone. A few different GI complications in the postoperative setting that seem to be related to immune checkpoint inhibitors. However, I think it's important to recognize that while we can throw out all of these anecdotal complications, if you look at the data, it's actually lower and less frequent than chemotherapy alone. And that's been consistently true across all of the trials, in terms of those types of things. And so the rate of getting to surgery for patients who had, chemotherapy with placebo seemed to be lower in several of these trials, or equal to patients getting chemotherapy with checkpoint inhibitors. So I don't think in any way we can say the addition of checkpoint inhibitors is decreasing our ability to get to the surgical finish line, and that was true across CheckMate, but also Aegean. I mean, multiple different trials showed the same thing. So I don't think that, even though we have these like anecdotal recollections, I don't think there's any real large scale evidence to support that the addition of checkpoint inhibitors is decreasing our ability to get to the operating room.